Hey everyone, and welcome to today's Facebook Live with GBMC Healthcare. So we're talking about a disease that often doesn't get enough attention, prostate cancer. Let's welcome our guest, Dr. Robert Brookland, a radiation oncologist at GBMC. He's here to give us some important facts about this disease and answer your questions. So please, guys, send your questions, and we appreciate the love and the support. Doctor, how are you doing?
Very well, thank you.
So give us a little background about what you do at GBMC.
I chair the Department of Radiation Oncology. We treat all forms of adult malignancies and a few benign conditions as well.
Gotcha. So what type of cancers do you treat?
Well, my main area is prostate cancer, but I do also treat breast cancer and certain other forms of gastrointestinal malignancies, colorectal cancer, for example, lung cancer.
Gotcha. So what makes radiation therapy different at GBMC versus other medical facilities?
One of the most important things that we have to offer GBMC is a phenomenal multidisciplinary team. And so we have specialists in all areas. We have lung specialists and breast specialists and gynecologic specialists and head and neck specialists. So we have a great team. And the teams meet to discuss patient care on a weekly basis. So in the same room, talking about the same information, but bringing in their own perspectives, will be medical oncologists, radiation oncologists, surgeons, pathologists, radiologists, all sorts of support team. We have phenomenal oncology nurses. We have folks that are experts in nutrition. We have geneticists, genetic counselors. We have just a great team. And in this multidisciplinary approach, you can really come up with the best plan for any individual and individualize that care plan for them.
Yeah, and patients really get that one-on-one interaction, right? Talk to us about that.
So, the support starts with their very first meeting with the physician to establish the diagnosis and do the evaluation test to see where is the disease or where isn't it. We have to decide what level of risk of disease are we dealing with. Is it a higher risk cancer? Is it a lower risk cancer? Sometimes you don't even need to treat cancer. Sometimes you can just carefully watch things. And then also there are others who are available to give advice in terms of good nutrition, for example. And so there's a lot of components that go into this.
Absolutely. So let's get into it. For those who don't know, what exactly is prostate cancer?
Well, cancer is a disease where cells divide without regulation, uncontrolled growth. There can be invasion by these cancer cells into the adjacent tissues and structures, and the cells can even dislodge from where they started and spread to other parts of the body. This is what cancer is. Prostate cancer starts in the prostate gland, which are only found in men. Women do not have to worry about this disease. And the prostate gland lives just below the bladder.
So what are some of those early symptoms that we should watch out for?
So interestingly, most men who have prostate cancer are found to have their disease not because of symptoms, but rather because of a screening evaluation.
And that's why getting the screening is so important.
Yes, so we screen for this disease with a digital rectal examination to see if you can feel anything abnormal on the prostate gland. And we screen for it by doing PSA blood tests. Most men who have urinary symptoms are having their symptoms not from the cancer, but just because as men get older, the prostate gland gets larger and it makes it more difficult to pass their urine. So the symptoms that most men have are not from the cancer, but just because they're getting older.
So how often should men actually get screenings?
For most men, starting their screening at age 50 is appropriate, and the screening would be the rectal examination and the PSA blood test. Then there are those men who may have a higher risk. For example, one could argue that African Americans are at a higher risk with prostate cancer, and most certainly men with a family member with prostate cancer are at a higher risk. And so you can move up their screenings to 45 or even 40 if there's a lot of family members with this disease.
Yeah, we talked about this off camera, but you know, my grandfather had prostate cancer. Fortunately, he's still here. Why is that African American men, you see this disease more prevalent in the African American community?
Yeah, so it's a great question, and more research is needed to answer that question. But the disease tends to be a more aggressive disease in the African American community, and so it's certainly important for men in general, but especially if you're at a higher risk, to go for those screenings to look for this disease because it's such a treatable disease.
Yeah, let's talk about that, how it is so treatable.
Yeah, so once one is identified as having prostate cancer, the next thing we do is figure out what level of risk are we dealing with. And the level of risk for prostate cancer ranges anywhere from a very low risk of disease to a very high risk of disease, and even beyond very high risk if it spreads regionally into the lymph nodes or more distantly into the bone. So we evaluate the levels of risk really with three major criteria. The first is how high is that PSA level. It's great when we can catch the PSA level when it's still less than 10. Above that would be a higher risk category. The second thing is, what does the cancer look like under the microscope? And here we are asking the pathologist to give us two pieces of information after the biopsy is done. The first is, how much cancer are we dealing with? Typically they take about 12 core specimens on a biopsy. And so is there cancer in just one of those 12 cores, or 3, or all of them? So how much cancer does it look like we're dealing with? The second thing we get from the pathologist is how ugly does the cancer look under the microscope? The pathologist assigns a grade to the cancer, and that grade can range anywhere from grade 1, which would be very close to normal, to grade 5, which is it couldn't look uglier. But the cells don't even always look the same in a biopsy, so they always give 2 grades to a biopsy. The first number tells us what most of the cells look like. The second number tells us what the rest of the cells look like. These numbers get added together, gives us something called a Gleason score, which are then put into one of 5 grade groupings. And so the most favorable cancers go into grade group 1, and the least favorable into grade group 5. And then the third thing that we look at to assess risk is the stage of the cancer. Most people have heard of cancer staging. And the staging for prostate cancer goes anywhere from stage 1, the earliest stage of this disease, up to stage 4, the most advanced.
Gotcha. But the good news is that the survival rate is high, right?
It's very high, and while the survival rate is the highest when we're dealing with the earlier stages of disease, even with more advanced cancers, this is still not just a treatable, but often a very curable disease. So even if I have someone with stage 3, sometimes even a stage 4A cancer, I'm going to aggressively treat that disease with curative goals as well.
Nice. Okay, so I feel like we have our first question. Do we have our first question? Oh yeah, we do have our first question. This is actually from Jimmy. How should you decide to treat it? Radiation or seeds or a surgical system?
Okay, so the 3 choices that Jimmy's asking about, radiation, seeds, and the Da Vinci surgical system, let me let everybody know what we're really talking about.
Yeah.
There are 2 ways that we use radiation with cure as the goal. One form is called external beam radiation therapy, where the radiation is delivered from the outside directed into the prostate. And the other form of radiation, the technical name for that is brachytherapy, when we put radioactive seeds into the prostate gland. So this is a one-time procedure typically, rather than the daily external beam radiation, which can take anywhere from 4 to 9 weeks.
Wow. And how long is that procedure?
Well, so the daily radiation treatments are 15 minutes a day for those treatments. The radioactive seed implantation, the brachytherapy, that procedure typically takes from between an hour to an hour and a half. Alternatively, one could undergo surgery and have the prostate gland removed, and that's called a radical prostatectomy. The older way of doing that was an open procedure where they made a larger incision to remove the prostate. And the newer approach is to use very small incisions and use the assistance of a robot to remove the prostate gland in a way that leads to less blood loss and quicker healing. Now, the good news for our patients is that the cure rates with the external beam radiation therapy, the radioactive seed implant, the brachytherapy, and the surgery, the cure rates are identical.
Oh, that's really good to know.
So since the cure rates are the same, we can make the decision, and to answer Jimmy's questions, how do you decide between the three? Well, we look at the logistics, the convenience, the side effects, personal preferences, that's fine. But we don't make the decision because of a difference in the cure rates, they're the same.
Gotcha. So some people might be a little bit hesitant about radiation treatment. Any advice for them?
Well, sure, and I would also say some people are a little hesitant about surgery also.
Yes, true.
So, you know, the concern that some people have with radiation is, well, doesn't radiation injure other tissues? And the risk of injuring those other tissues was greater many years ago. When I was in my training, we did what we would today call conventional radiation therapy, but those conventional techniques did cause more injury to the adjacent tissues. Fortunately, we are about 4 generations of radiation beyond what we did back in the 1980s or 90s. And so today we have wonderful technology that allows us to give much higher doses of radiation than we were able to previously with much fewer side effects.
Yeah.
So we now have outstanding cure rates with very few long-term late effects. So we have great technology now to allow us to do this safely. 2 of the technologies that we use, one is called image guidance, where each day before the radiation, you actually image the prostate, and we make sure that we have it dead center before we give the radiation.
That's awesome.
It's possible the gland could move a little bit one day to the next, maybe a little more pressure coming from the rectum or the bladder day to day. We see that and we adjust the positioning first. That way we can be pinpoint precise in our targeting. And then another technology we have is called modulated radiation therapy, where the beam comes in a very sophisticated way, usually with the machine rotating around the patient several times during the administration of the treatment. And this allows the doses to be highly conformal just to the prostate while minimizing the doses to the rectum and to the bladder, hips, etc. So it's a much, much safer treatment. And some of the stories that we may have heard are from people who were treated with the older technologies.
Well, that's good to know. There's several options out there available.
Yeah,
definitely. So we have another question. This question is from Shelly. So Shelly said, is there a link between prostate cancer and breast cancer? If so, what does that mean exactly, doctor?
Well, Shelly is asking a question about the linkage between prostate and breast cancer. And the link is that there are some women who get breast cancer and some men who get prostate cancer who are getting it because of a genetic mutation. And so when we have histories of other family members who have breast or prostate cancer, we can sometimes see a pattern in the family history, and then we generally at GBMC refer our patients to our genetic counselors at the Harvey Center for Human Genetics. And what they do is they take a detailed family history and then figure out what genes should we look at for mutations. And then by a blood test, we can send off, look for those mutations, and if they're present, that gives additional information, not just that's helpful to our patients, but also their entire family as to how to look for higher risks. How do we better screen? Does this have an implication in terms of how we do imaging or physical examinations? And there are other cancers where there's genetic causes for cancer. Certain colon cancers are an example. So when we find patterns in the family of cancer, not a bad idea to find out whether or not genetic testing would help us to keep a closer eye and see who's actually more at risk for this. That will sometimes help to make decisions about the best type of treatment, as well as how to keep an eye on things.
Exactly. That's an incredible resource. So we have another question. This question is from Tyrone. So his question is, should you worry about the size effects after surgery, and what are they?
All right, well.
Side effects.
So after surgery.
Because, people are so worried about that.
Yeah. Generally, immediately after surgery, I mean, there's always a risk with surgery. Could there be bleeding? Could there be an infection? These risks are pretty uncommon. It is not uncommon for the surgeon to advise their patients to take off from work for anywhere from 3 to 6 weeks to adequately recover from the operation. The major risks after longer term after surgery fall into really two categories. Problems that can affect urinary functioning and problems that can affect sexual functioning. Now, the urinary symptoms with surgery most commonly would be loss of control of the bladder. Almost everybody after this big operation has problems with bladder control, but within about a month, about a half of our patients have recovery of their bladder control. When we get out to about a year from surgery, almost everybody has recovered from loss of bladder control. But there may be a 10 or 15% number of patients who still have some urinary incontinence even that far out. There are some surgical procedures that can be offered some of those men to recover from the problems with urine leakage. So that's one of the late effects of surgery that a small number of men will have. Within the area of sexual functioning can be negatively affected in two ways. One is that some men are still having, still getting their erections and having a climax, but nothing comes out when they have their climax. It's dry. That happens to everybody with surgery. More concerning to most men is the actual loss of ability to get an erection. And that does happen a lot. At least a third and probably closer to half of the patients who have surgery are going to have some level of erectile dysfunction. The surgeons are able to reduce the risk because it used to be just about everybody, but when they developed what is called a nerve-sparing operation, they found that they could reduce the risk of losing the ability to get an erection. If they can spare the nerves on both sides, they can preserve potency in as many as 2/3 of the patients. If they can only spare the nerve on one side, it may drop to about 1 out of 3. Now, the good news for the men who have erectile dysfunction, whether it's after surgery or radiation, which can also cause that, the good news is that there are 4 different strategies to deal with erectile dysfunction so men can get back to where they like to be, whether it's oral medicines, injectable medicines, pumps, or implants. One of those 4 strategies will work given somebody's motivation and interest in that.
Okay, so let's go back to screenings right now. Can men go to their primary doctor, or do you actually recommend a specialist?
No, I actually recommend that men have discussions with their primary care physicians about the potential benefit for screening. The official position of the American Cancer Society is not that all men should be screened, but rather that all men should discuss with their primary care physicians whether or not to be screened. My own bias is yes, all men starting at the ages that I discussed earlier, at least age 50, should be screened. But I think that they should start with a conversation with their primary care physician. You do not have to see a specialist such as a urologist or a radiation oncologist for screening. Primary care physicians are well positioned to work with their patients for screening.
Is there any lifestyle changes that men can do to prevent prostate cancer?
I wish that I could give a couple of good tips for how to prevent prostate cancer in particular. But I do have some recommendations about general good lifestyle changes, and they fall into the categories of nutrition and exercise. From a nutrition standpoint, healthy eating, lots of fruits and vegetables, minimizing and in fact we recommend up to 11 servings a day of fruits or vegetables. Protein sources should be more plant-based than animal-based. And if you're going to eat red meat, personally, I think once a week is about enough for red meat.
Once a week?
I would think so. I think we should be getting more of our proteins from fish. Poultry is better than red meat. Then keeping down the fats, certainly keeping down the simple carbohydrates, more complex carbohydrates. Vegetables are terrific. Fruits are terrific. Baked products, not so good. And then exercise. Very important to get a lot of exercise. 150 minutes a week of aerobic exercise, maybe some weight training 3 times a week. These lifestyle changes, avoiding obesity, being physically active, watching your diet, this is going to keep people healthier both from a cancer standpoint, but also from a heart standpoint.
Absolutely. It's those simple things in life that speak volume. Take care of yourself, guys. It's so important. So talk to us about the different types of tests. The PSA tests, talk to us about that.
Yeah,
We'll talk about the other one as well.
So really, the main way that we screen for prostate cancer is to combine a PSA blood test with a rectal examination.
And what's the difference between them?
The PSA blood test is looking, PSA stands for prostate-specific antigen. This is a protein that is made in cells that originate in the prostate gland. So normal prostate cells will make this protein, but cancer cells are going to make a disproportionate amount of this protein. If this protein level goes up beyond a certain level, that's a warning indication that maybe you should think about a biopsy. So we do tend to see the PSA levels creeping up a little bit as we get older. So for a younger man, you'd probably expect the PSA level to be under 1 or 1. Maybe as we get older, it may get closer to 2. If the level is getting over 2.5, that might trigger some additional testing evaluation, and the urologists are pretty sophisticated about doing other types of derivative tests on the PSA to look at the percentage of free PSA, and there's some other tests that they can do to try to increase the likelihood that if they're going to take someone for a biopsy, there's a reasonable chance that there could be a problem to look for.
Yeah.
Maybe I was going to say the non-invasive way, but I would say the minimally invasive way of looking for prostate cancer is for a physician to actually feel the prostate gland. If you can feel a nodularity within the gland, that may be a tip-off that there's a problem also. So these are the two major ways that we screen for prostate cancer: feeling the prostate gland, doing a PSA blood test.
Gotcha. And we have another question. This question is from Laura. So, do radiation treatments have the same side effects as surgery? What's your thoughts, Doc?
Okay, so I would say that the answer is some of the side effects are similar to surgery, some are a little bit different. So let's break it then into 3 areas from a quality of life standpoint. There's the quality of life from a standpoint of urinary functioning, from sexual functioning, and from gastrointestinal or rectal functioning. From a urinary standpoint, we can see with radiation short-term increased urinary frequency, maybe some urgency, a weaker stream, some discomfort with urination. These side effects start to fade away a few weeks after the radiation treatments have ended and get back to baseline within about 6 months or so. The late urinary side effects that one could see, urinary incontinence, this, and I already mentioned this from an outcome with surgery, that there's a very high risk of urinary incontinence with surgery compared to radiation. With surgery, that number is not less than 5% and maybe 10, 15% from a surgical standpoint. From radiation, the risk of urinary incontinence is only 1 or 2%. So from a urinary quality of life standpoint, several studies have shown that the quality of life outcomes are favoring radiation over surgery. Now let's look to rectal and gastrointestinal quality of life. Here with radiation, you can see during treatment some itching, see a little blood or mucus, or a change in the bowel patterns. Once again, these side effects start to fade away a couple of weeks after the radiation has ended, and again go back to baseline within 6 months or so. Once we're out a year or so, the likelihood of having any problems is quite low. It's not 0. So there's a slight advantage of surgery over radiation, because with radiation, sometimes a man is going to have a bowel movement and see a little blood, but usually it's like having a hemorrhoid. We know what caused the irritation, and we can ignore it. And we only prescribe something in fewer than 5% of our patients. Finally, within the area of sexual functioning outcomes favor radiation over surgery because there's less likelihood to have erectile dysfunction, but it could still happen with either radiation or surgery, and fortunately the same solutions can work either way: oral medicines, injectable medicines, pumps, or implants.
So I've heard that some patients don't even need treatment at all. Do you recommend that? Is that safe?
Yes, I think that if we can identify men who have a low or a very low risk of cancer, we can just watch these gentlemen for many years, and I'll give you an illustration of that. And to me, the analogy is for these low-risk prostate cancer patients, it's sort of like, imagine that you're in a car and you know the car is heading towards a cliff, and you've made the judgment that given the speed that you're traveling and the distance to the cliff, you're not going to reach that cliff, so why do you have to slam on the brakes? Maybe you could just coast along and enjoy the ride. But with prostate cancer, it's not as though we're so supremely confident of that judgment that we don't want to keep our eyes open, because if it looks like we are getting too close to the edge, we want to be able to apply the brakes in time. So with active surveillance, we monitor things with PSA testing, with rectal examinations, and once in a while repeat the biopsy. And if you do that, you can offer men active surveillance. I did this for my stepfather. What we did with Marty, when we found his prostate cancer when he was 58, I watched his cancer for 10 years. When he was 68, with active surveillance, we saw that the cancer looked a little bit more advanced than it had earlier. At that point, we offered him treatment. I treated him with a combination of hormonal therapy, 25 radiation treatments, and then we did the brachytherapy to put the radioactive seeds in. Marty lived another 17 years past his treatment, and when he passed away at age 86, from something, a neurological disease, he was cancer-free. So that's an example of someone who went 10 years with no side effects from treatment because he wasn't even treated. And when we did treat him, he was still able to be cured. So I think that it is very possible to offer men active surveillance if they have a low or very low risk cancer.
It's good to know that there's so many different types of options. It's very important. And you have an important role in a textbook. Talk to us about that, Doc.
Well, you asked me earlier about risk factors, and one of the risk factors that I mentioned well, there are three risk factors that we look at. How high is the PSA? How ugly do the cancer cells look like under the microscope? And the third is, what is the stage of the cancer? You know, we need to talk with a common language when we're talking about cancer. And the common language when we're talking about cancer is staging. So the organization that defines how we stage all forms of cancer, whether it's lung cancer, breast cancer, colon cancer, or prostate cancer, is the American Joint Committee on Cancer. The American Joint Committee on Cancer is really a multidisciplinary organization. We have physicians and scientists from all over the country, from all specialties. And we define, and I say we, I'm the vice chairman of the AJCC.
Awesome.
And we define how we stage all forms of cancer. The 8th edition just went into effect this past year. We have had over 400 physicians and surgeons working on the 8th edition. We worked on it for over 3 years before it was published, and this is now being implemented nationwide. So the rules of the AJCC establish how we define and stage cancers, and when we're making decisions about how we treat any cancer, one of the first questions people want to know is, what stage am I? Prostate cancer is divided into 4 stages. Some cancers, like breast cancer, we even have a stage 0 for some cancers. So it's very important that we talk the same language, and staging of cancers is that language.
Well, doctor, thank you so much. This conversation was much needed. Any last minute advice for our viewers?
Yeah, I think prostate cancer is nothing to fear. We have a disease that we have so many different treatment options. It's a very treatable disease. It's a very curable disease, but we shouldn't avoid looking for problems just because we don't want to find them. Instead, by finding this disease early, it gives us great chances for success in its treatment. So I would encourage all men at age 50, even earlier with risk factors, to see their primary care physician and talk about screening so we can find it early and decide if we even have to treat it.
Absolutely. And where can we find more information?
Well, we can go to the American Cancer Society's website at cancer.org, and the Cancer Center, the Sandra Malcolm Cancer Center at GBMC is a wonderful resource for people in our community.
Thank you so much. That information is on your screen. And doctor, it was a pleasure chatting with you.
It was a pleasure chatting with you.
I learned a lot.
Thank you.